Welcome back to another CHT prep for the year of 2024. It is now August, which is so crazy. I can't believe how fast the summer is flying by. I'm so sorry that I missed doing one of these videos in July due to unforeseen illness. I had COVID for the first time ever, and it was horrible. I hope you are all staying healthy and your families are staying healthy and well. But we are back. It is August. It is time to get back to business. If you're new here, this is how this video is going to work. We'll go through 15 CHT prep questions that are going to give you some practice for the CHT exam. Pause the video as many times as you need to. Make sure that you commit to your answers. We'll take a pause halfway through after we get through the questions, and then we'll go back through and go through the correct answers. So that's how this format will work. As always, let me know any feedback that you have in the comments below, and good luck. Question 1. In a patient with rheumatoid arthritis, chronic synovitis of the PIP joint puts stretch on which structure, leading to development of swan neck deformity? A. Oblique retinacular ligament. B. Central slip. C. Volar plate. D. Intrinsic muscles. Question 2. A patient with a terrible triad elbow fracture begins to report elbow pain, weakness in grip, and paresthesias in their small finger. What would the therapist likely implement in the treatment plan? A. Static progressive orthosis to promote improved range of motion. B. Fabricate an elbow extension orthosis for nocturnal wear. C. Refer the patient to the surgeon as they have signs of heterotrophic ossification. D. Add therapeutic exercises to facilitate improved grip strength. Question 3. Which of the following is an appropriate goal in treating a yellow wound? A. Prevent desiccation. B. Absorb drainage. C. Debridement. Or D. Facilitate autolysis. Question 4. Which of the following is an intrinsic factor of shoulder impingement? A. Acromion anatomic variations. B. Glenohumeral muscle imbalance. C. Glenohumeral joint capsule tightness. Or D. Flexed or slouched thoracic posture. Question 5. A patient has been referred to hand therapy for a whirlpool treatment after a traumatic hand injury. What temperature should the whirlpool be kept? A. 74 degrees. B. 84 degrees. C. 94 degrees. Or D. 104 degrees. I should have clarified this is temperature in Fahrenheit also. Question 6. Which of the following muscles is innervated by the anterior interosseous nerve? A. Flexor pollicis brevis. B. Pronator quadratus. C. Lumbricals to the index and middle finger. Or D. Opponens pollicis. Question 7. What percentage of force with loading is transmitted through the radiocarpal joint? A. 20%. B. 30%. C. 50%. Or D. 80%. Question 8. The space of Poirier is between which carpal bones? A. Scaphoid and lunate. B. Capitate and triquetrum. C. Hamate and scaphoid. D. Lunate and capitate. Question 9. The accuracy of the tool used to measure data is known as A. Reliability. B. Validity. C. Sensitivity. Or D. Specificity. Question 10. In fabrication of an ulnar gutter orthosis, which bony prominence is at risk for skin breakdown? A. Fifth metacarpal head. B. Ulnar styloid. C. Radial styloid. D. Lateral epicondyle. Question 11. In a radial nerve injury, which of the following orthosis designs best describes correct positioning to prevent joint contractures? A. Anti-claw orthosis with the MCP joints positioned in flexion. B. Thumb spica orthosis with the thumb in abduction. C. Wrist orthosis with MCP joint extension assist. Or D. Elbow extension orthosis. Question 12. The cell bodies of motor neurons are located within A. The dorsal root ganglion, B. The anterior horn of the spinal cord, C. The ventral root, or D. The dendrite. Question 13. A patient has undergone 6 weeks of immobilization after a closed boutonniere deformity, and you initiated active flexion exercises at your last treatment session when the PIP active range of motion measurements were as follows: 0, 30. Today, the patient presents to the clinic and PIP active range of measurements are as follows: 10, 30. Based on this progression, what would be the most appropriate course of treatment at this time? A. A static progressive orthosis should be initiated immediately to regain PIP extension to 0. B. Increase flexion exercise sessions and add hook fist exercises to the program. C. Decrease flexion exercise sessions and resume the PIP extension orthosis between exercise sessions. D. The patient should continue with PIP active flexion exercises as previously prescribed. Question 14. Which peripheral anomalous innervation is between the ulnar and median digital common nerves in the hand? A. Berrettini anastomosis. B. Rich-Canu anastomosis. C. Martin-Gruber anastomosis. D. Marinacci anastomosis. Question 15. In flexor tendon rehabilitation, the sum of the forces resisting digital flexion, including edema, bulk of the repair, adhesions, friction of repair, and joint stiffness is known as A. Quadriga effect, B. Work of flexion, C. Total active movement, D. Controlled stress. Okay, congratulations! You made it through 15 CHT practice questions. Go ahead and pause the video now if you need a little bit more time to go back and review. Make sure that you commit to your answers, and we will go back through the questions now. I'm going to tell you which answer is most correct out of all the options and provide a rationale. Question 1, the correct answer is C, the volar plate. Oblique retinacular ligament ORL issues would typically lead to hyperextension of the DIP, kind of what presents in boutonniere, and then central slip obviously is a boutonniere deformity. It's going to cause PIP flexion and DIP hyperextension over time. The intrinsic muscles doesn't really make sense for this question. Question 2, the most correct answer here is B. The symptoms are descriptive of cubital tunnel or ulnar nerve impingement type symptoms. So static progressive may be good for terrible triad if you're having ROM difficulties, but not necessarily to help with the cubital tunnel symptoms listed here. The description really doesn't indicate heterotrophic ossification, so that's probably not the correct answer. And then therapy putty will not help to improve the nerve symptoms. Question 3, the correct answer here is B, absorbed drainage. For this, I would just think about the different wound colors and kind of the goals of treatment of each phase of wound treatment. So debridement and autolysis are more descriptive for like a black wound or eschar. We always want to prevent desiccation, but with a yellow wound, the most relevant primary factor is absorbing the drainage. Question 4, correct answer is A, acromion anatomic variations. This is an intrinsic versus extrinsic factors. The other factors listed below are all extrinsic factors. 5, correct answer is C, 94 degrees. If this was a challenging question for you, look back at your PAMs and the thermal modalities section, kind of look up the temperature ranges for whirlpool, paraffin, hot pack, all that kind of stuff. Question 6, the correct answer is B, the pronator quadratus. So this is a little bit of a tricky question. The FPB especially is sort of the trick question here because there are two heads. There's the superficial, which is innervated by the recurrent median nerve, which is actually a branch that comes off of the median nerve after it's given off the anterior interosseous branch. And then the ulnar nerve supplies the deep head. The lumbricals to the index and middle finger are, again, not the anterior interosseous, it's the median nerve branch, and then opponens pollicis is ulnar nerve. Question 7, correct answer here is D. 80% of force is coming through the radiocarpal and 20% through the ulnocarpal. Question 8, the correct answer is D, between the lunate and capitate. This is a purely anatomical question, so it might be good to go back and review the different carpal bones and some of those kind of funky names of anatomical spaces. Question 9, everybody's favorite, statistics. Sense my sarcasm. The correct answer here is A, reliability, so that's the accuracy of the tool. The validity is the extent to which a test measures what it's supposed to measure. The sensitivity is the probability of a positive test conditioned on the individual truly being positive, versus specificity, which is the probability of a negative test conditioned on the individual being truly negative. Question 10, correct answer here is the ulnar styloid, B. Radial styloid and lateral epicondyle would not be included in a traditional ulnar gutter orthosis, and the fifth metacarpal head just tends to not be as much of an issue. It could be an issue if it's more of a proximal phalanx fracture that you're doing an ulnar gutter for. That could be potential. I haven't personally seen that a lot in practice, but typically with a ulnar gutter, forearm based, the ulnar head is typically, the ulnar styloid is typically problematic. Question 11, correct answer here is C, the wrist orthosis with MCP joint extension assist, because typically with radial nerve injury, you'll see the wrist drop, they won't be able to extend their fingers. Anticlaw is going to be for ulnar nerve, thumb spica in abduction is median nerve, and then elbow extension orthosis would help probably more with like a cubital tunnel syndrome, so not necessarily a nerve palsy. Question 12, correct answer here is B, the anterior horn of the spinal cord. This is purely a neuroanatomy question. I don't really have a rationale, just a fact. So if this was a hard question, I would recommend going back and look at your neuroanatomy, the functions of the parts of the cell, and a neuron. Question 13. The correct answer here is C, decreasing the flexion exercise sessions and resuming the extension orthosis between those, because PIP extension in this case was actually getting worse. And so you would want to decrease the amount of flexion exercises to slow that down a little bit. Static progressive is used when the passive range is not passively correctable. And you wouldn't want to increase flexion exercise sessions since the the PIP extension is getting worse. You also wouldn't want to continue as if nothing has changed. Question 14, I'm sorry I probably butchered all of those names. The correct answer here is A, Berrettini anastomosis. The Risch-Canu is an intraneural communication between median and ulnar nerve in the hand. Martin Gruber is median to ulnar in the forearm, and Marinacci is reverse Martin Gruber, so ulnar to median in the forearm. Finally, question 15. The correct answer here is B, the work of flexion. The quadriga effect is the reduced flexion of non-injured fingers, most likely due to injury of the FDP, due to the connection. TAM, or the total active motion, is a way of expressing range of motion of an entire finger by adding the motions of each joint and subtracting the restrictions or limitations. And then controlled stress is the concept of applying controlled stress with tendon repair. Thank you so much for watching this video. I hope it was helpful. I hope you enjoyed it as much as one can when you're studying for a very stressful exam. Let me know if you have any comments, feedback, questions, anything to add. Please comment below. If you enjoyed this video, give it a thumbs up. Make sure that you are subscribed to the channel so that you never miss a hand therapy video. And I'll see you in the next one. Thank you.